Understanding vaginal hysterectomy for pelvic organ prolapse. Prolapse is the loss of normal support of the vagina and/or the uterus. Prolapse of the uterus and/or the vaginal walls is common, with up to 11% of women requiring surgery during their lifetime. Prolapse generally occurs due to damage to the supporting structures of the uterus or the vagina. Weakening of the supports can occur during childbirth, following chronic heavy lifting or straining, chronic cough, obesity, and as part of the aging process. In some cases, there may be a genetic weakness of the supportive tissues. Prolapse of the uterus can cause an uncomfortable bulging sensation, a feeling of fullness or pressure in the vagina. In a more advanced prolapse, the cervix, which is the organ that is the opening to the uterus, can extend beyond the entrance to the vagina. In some cases, surgery is recommended because your uterus has fallen or is dysfunctional. Surgery involves removal of the uterus, which is called a hysterectomy. A hysterectomy can be performed by many routes, including abdominally, laparoscopically, or vaginally. The route is determined primarily by the size and mobility of your uterus. A gynecologist will perform the surgery and determine which route is best for you. A vaginal hysterectomy offers many benefits over abdominal or laparoscopic hysterectomies. It provides overall fewer complications, shorter healing time, less scarring, a lower chance of infection, less risk of hernias, and faster return to activities. Also, a prolapsed uterus is easier to access via the vagina. A vaginal hysterectomy operation is frequently combined with prolapse repairs of the bladder and/or the bowel. There are no abdominal or laparoscopic incisions. When surgery is recommended, you will need to meet with a vaginal surgeon called a gynecologist. Most patients are anxious about meeting a surgeon, but being prepared with questions will help you get the most out of your visit. Finding an experienced vaginal surgeon is critical. Locating an experienced vaginal surgeons will often work with a multidisciplinary team of specialists, such as pelvic floor physical therapists and nurse practitioners, who will make your subsequent care easier. Please make sure you are comfortable with your vaginal surgeon and that you trust their judgment and expertise. Remember that you would likely have a several-year ongoing relationship with the surgeon, so choose carefully. Discussing the pros and cons of the different hysterectomy options is critical. In addition, make sure to review the details of the surgery and go over any risks. Remember that the female organs include the vagina, cervix, uterus, fallopian tubes, and ovaries. Options for vaginal prolapse surgery usually include the cervix and uterus with or without your fallopian tubes and ovaries. Generally, a vaginal hysterectomy is performed in the hospital under a general or spinal anesthetic and takes approximately 1.5 to 3 hours. During surgery, a cut is made inside the vagina around the cervix. The uterus is disconnected from its blood supply and then carefully removed from around the bladder and rectum. After confirming there is no bleeding, the surgeon removes the uterus and closes the top of the vagina, now known as the vaginal vault. Many surgeons will choose to add additional support stitches to the vaginal vault at the time of surgery. The vagina can be tied high in the pelvis to either the uterosacral ligaments that support the uterus or to support structures on the side of the uterus. 85% of women having a vaginal hysterectomy for uterine prolapse are cured permanently. About 15% of women develop a further prolapse of the vaginal vault months or years after their first surgery. These figures may vary depending on the severity of your original prolapse. A vaginal hysterectomy is delicate because the pelvis is a tight area with many important structures passing through it. Here are some risks that your surgeon will review with you. There is a slight chance of bleeding with any surgery, and the likelihood of bleeding for this particular operation is around 2 out of every 100 people. To help reduce the chances of bleeding, most surgeons recommend stopping medicine such as aspirin or ibuprofen. There is a slight chance of injury to the bladder and ureters, which connect your bladder to your kidneys. This would require you to go home with a catheter for a few days. The bladder is relatively large and travels between the uterus and the pubic bone, right where your surgeon will be working. The ureters can be stretched, bruised, or damaged during vaginal surgery. Even in the most experienced hands, 1% of patients who have vaginal surgery have damage to the ureters, requiring more extensive surgery and a longer recovery. In the first few days after surgery, difficulty passing urine can occur in up to 10 to 15% of cases. You may need to have a catheter for a few days after surgery until you can easily pass urine. 6 to 20% of women having vaginal surgery develop a urinary tract infection. The risk is highest if you have had a catheter. Symptoms include burning and stinging when passing urine, as well as urinary frequency. Regarding recovery from vaginal surgery, most patients go home from the hospital the same day, and there are traditionally no surgical drains. Stronger pain medications are generally only needed for a few days. You should drive and be fit enough for light activities, such as short walks, within a few weeks of surgery. You are advised to avoid heavy lifting and sports for at least 6 weeks to allow the wounds to heal. Remember that your surgeon and their team will be there for you if you need advice or help in the future.